we're almost close to the end. We have one more set of speakers to go, and then we'll have the closing. So if we can, for those of you who are eager to get to the reception at the end, we have not much longer to go, and then we'll be able to share our drinks and talk about all this stimulating intellectual matter over some nice wine. My name is John Simon. This is the second panel I've moderated in the last 18 hours. The first one was on the other side of the Atlantic in Washington on agricultural finance. So if I slip into talk about warehouse receipts or commodity trade finance for rice, you'll know why that is. But we're going to try and keep things very, very quick. We have a very distinguished set of panelists. You can see their bios in the handout that's in the folder, so we won't get into talking about them, but trust me, they have quite a impressive set of experiences to share. And I just want to say one thing, and then I'll hand it over to Jacques, who will then hand it over to the panelists and ask them each for just one lesson, in the interest of efficiency and prioritization, just one lesson that they would identify in 5 minutes or less as the most important to learn from our experiences in this area. I should say that the title of this conference, When Markets Fail, presumes that there's a solution to market failure. But just like in healthcare, sometimes a cure can be worse than a disease. And when that happens, you have to go through a painful process of finding out what cures work and what don't, what addresses the problem without causing other more dangerous side effects. And the only way that happens is if we learn from each effort. And the real benefit of my relationship with Farm Access is I've been heavily engaged in the area of impact investment, heavily engaged in the area of trying to mobilize capital into enterprises that not only have a financial return, but also make a real social purpose. And in this area, there's no shortage of people who are talking about this subject. But for the last 9 or 10 years, as I think we've heard today, the folks from the Farm Access Foundation and the Farm Access family have really been doing it. And it's from that doing that we can learn the most. And so I want to have this session really focus on what has that experience brought us in terms of the right path for the way forward. Jacques, any words?
Yeah, no, I will not say anything because I already spoke, but maybe I throw a few words out during the discussion. I would say, ladies first. Monica, why don't you take up the challenge? Tell us what you have learned from all this intellectual stimulating talks and all the work that has been behind it, and all that in 2 minutes or less. All right, 3 minutes or less.
Thank you very much. Actually, it has been an honor because, as you heard from Monique, we just launched the Medical Credit Fund initiative in Kenya. And today, although I arrived a little bit late, have learned a lot. Because for a long time, as a service provider in Kenya, I work with a network of health providers in the rural Kenya, where 80% of the population live. And it's a big challenge when communities go searching for quality of care. And to sit in a forum like this and listen to so many people from the economic background, non-medics talking about improving access, it has been really satisfying. What really made my day are the different levels where we can involve different people to ensure that we improve access to quality services. From today's discussion, I've realized that everybody has a role. If we are to improve access to quality of care in Africa, we need to involve the policymakers. We need to involve the investors. For a long time, I think the investors saw the health sector as a risk sector. But from today's discussion, I think we have seen that there is need to invest in health sector. We need the health providers. If we involve the health providers, they are longing to see or to have quality care in the facilities, but they don't have the means. So I think with the economic support, they'll be able to offer the services. But we also need to involve the community, the consumers of the products, Because until the community appreciates the services that we put in place, we can have good health facilities with high standards of quality of care, but underutilized. So I think in a nutshell, because you told me to take 1 minute, from this room, all of us, if we decide today, I think we'll be saving so many souls in Africa because we can. Thank you.
I'm Willem van der Put of HealthNet, and we try to set up health systems in fragile states, in countries where we actually start our thinking from Esther Duflo. So I'm happy to see that that knowledge has arrived then, but basically the whole idea is that when people are working or living in situations where it's not only the market that failed, but basically everything in life has failed, it is difficult to come up with a new idea, and it's even more difficult to accept quite well-ingrained ideas from our world. I think it's one of the main issues that we're dealing with, but that is why I believe, and that has been stressed again today with the successes that have been presented, is I'm absolutely sure that the fact that we live in, or that we work in those countries where there is no market yet, where there is no private sector yet, where there is no middle class yet, that the cooperative approach, used backwards, so to speak, will be very effective. That's what we're trying to do in Cambodia with the help of Achmea, where we have worked out with people from the Rabobank how a cooperative approach is actually useful to reinstall trust in a society by showing success. The kind of work that we used to do before by helping people to move forward again, to mobilize them after being totally hopeless and depressed, etc., proved out to be much more effective if you actually start working on tangible stuff and not only leave people there when you think that now you're up to yourself again. One thing again, the last sentence, this is what I heard, I don't know why, but always if I'm with the farm access people, I suddenly think about all captains of industry. I don't know why, but I was hearing from Mr. Herkstreuter of Shell once that he didn't really understand why there was so much to do about mental health and trauma. He said, when we rebuilt Rotterdam after the Second World War, we didn't need trauma teams. And it took me a long time to understand why this was not just insulting, but very wrong to what is now going on in the countries where we work. These are people that do not cope with a one-time event. These are people, as Onno said before, that are living and have always lived in a totally hopeless situation. In order to bring them out of it, we need all the experience from the financial markets and definitely also from people like Esther Duflo who are translating that knowledge to us. So I think we're on the right track with this experience. From our fragile states, we'll look at how you do and try to catch up.
I'm Serge Heijnen. I'm the area leader held at the Royal Tropical Institute. I have to disclose here at the moment that I'm a public health person in that. And yeah, that's boo. What? yeah, that's right. So. And I also have to disclose, as I spent most of my working life as an advisor to ministers of health, actually in that. So in the public sector in that. So I will disclose that now because it gives also a bit of the background. I've spoken many times also with Onno and with Joep, and he always surprised me with many of the ideas. I must say what I've learned today, which is very important, is that there is now a serious private partner and a private investment partner in Africa. Many times when you were advising the government, look from the public perspective, there was not really somebody to talk to in the private sector also. There were no investors, there were no real quality facilities, and there was no organized society in that to talk to. So no wonder sometimes that ministers turn their head only to the public sector and see how they can improve the services with all that. What I've seen now is tremendous growth in all the activities that you are doing in there, and I'm really, I must say, I'm really impressed with what is going on at the moment. But to bring back my public health glasses then again, I think the proof of the pudding is in its eating, in the sense that when you have to convince ministers of health, and because there are also innovations taking place in the public sector, and in many countries also trying, where the public sector is increasing its financing and its things in there. And the Minister of Health needs to know, what should I do then, given these things? What is the right model of doing in there? But the proof of the pudding, he will look at the Minister of Health. He will look at, well, how much health is it going to give me for the money I will need to invest in that, or what is going to do? And also what type of financial sustainability is being given, and security to people in that. I've seen today a tremendous amount of activities and new investment funds as ever, and I'm really look forward to hear and also to participate, hopefully, in the research on seeing then also the effects of what has been done in there, because only there you can prove that say that also the private sector can make a real lasting effect on health and that, and then it means that you can come back to the minister again and says, hey guys, there is an alternative at the moment. Okay.
Thank you very much. I'm Kamaruga. I work with I head the Health in Africa initiative, which is a World Bank Group initiative. Two things. The first thing that I've learned on a light note is that don't stand between a Dutchman and his dinner. That is the only time when he can exchange his glass of milk for a glass of Heineken. So I will not stand on you. But most important, there was a slide that I wanted to share with you. Is that slide there? This is the Health in Africa initiative. Look at the 3 circles there. The synergies between research data, the technical assistance that is given to governments and private sector in changing policy and regulations, and access to finance. This meeting has reconfirmed to me that these 3 things must be done. And I can see that the high rate of fertility, of farm access, they are now very big in the family, is partly to respond to this. Let me explain. First, although the private sector is a provider of over 50% of healthcare, most governments don't acknowledge it. And there's ways in which this data has to be presented in a manner that it is owned by government and the people in the country so that they act accordingly. And that is something that we are doing as much as possible. We have seen the tremendous change that the Red Book, the Business of Health in Africa, has made in the debate. We have seen the extent to which the changes, some of the analysis that we've done in country on what is happening in the private sector in a country, and we have now 6 countries with very, very good data have done. And recently, we published this one, Healthy Partnerships, and the debate that is bringing on government agreeing that they're not doing enough to embrace the private sector is critical. 2 is that there is no way any of these things we're doing can be sustainable if policies and regulatory environment in our countries do not change. You're working in countries that still have medical and health laws that are pre-colonial. They do not have the advantages of moving to where we are right now. The regulatory bodies, the boards don't work. They are underfunded, they are understaffed, and they cannot therefore enforce whatever quality standard safe care may want to bring into a country. So that is an important area, and that work we see as important, and we are moving ahead with it. The policies then that recognize the private sector as being an equal partner in self-delivery and not just another figment of that is also important. And increasingly, we are seeing demand from African governments saying that we want to be helped to engage better with the private sector. 3, 4, 6 countries now that we've worked in have established a full department of private sector participation. Previously, there was none, or there was a desk which had one person who did everything else except private sector work. Two, that the private sector itself, as everybody has said, has been fragmented in Africa and had no voice. The only bit of private sector that had some voice were the faith-based. But they are not all. So now bringing them together under an umbrella federation in every country gives them a voice. So that's important. Third is the area of access to finance. And that finance must not always come from outside. And there is vehicles, innovative ones, that must be used. It cannot be business as usual. And that's why I love what the Medical Credit Fund is doing and all the work on insurance. But did you know this? That last year, the African heads of states declared this as the decade of health insurance in Africa. How many of you know that? And that is the first political admission that they have to move beyond where they've been in health financing. And remember, health insurance is first and foremost a political decision. If there is no politics behind it, no economics can bring it on board. So now every year when the heads of state in Africa meet in Addis Ababa, each country has to report on where they are in moving towards social health insurance. And you know what's happening? Every country right now is struggling to start one. But what do we have to show for it? Right now, Africa has 4 models of health insurance that have delivered health insurance to more than 20% of the population. The first one is the South African Zimbabwean one, which arose from their history, but is now struggling to come up with a new model that covers the underprivileged population that were never covered before. And that's a big struggle. Second one is the Rwanda model, which is so much funded by external resources that is unlikely to survive on its own. The third one, but it's covering 90% of the population. The third one is a Ghanaian one, which is almost 100% funded by the Ghanaian exchequer. No contributor money into it. And they put the money there, but they have their management problems that need to be sorted out. And the fourth one, and the Ghanaians is 60% coverage. The fourth one is a Kenyan one that has grown out of 40 years of experience, covers 20% of the population, but all the money is contributor money. There's no employer money on it, there's no government money on it. So these 4 are critical ones in terms of where we move forward, because every country is asking, what do we do differently to be able to cover people? That's a critical area for us to move forward. So if you ask me what lessons are there, the synergies must work. It's not money alone, it's not regulation and policies alone, it's not knowledge alone, but it is combining the 3 to take advantage of the political will that is now there to move health and health insurance and coverage in Africa. Thank you.
Yes.
Arno?
Well, it's for us, because we're not living in Africa, so we're talking here as Westerners. We started with something I think that is the most important thing, knowing what is going on at the bottom of the pyramid, and at the same time living here. And we, in my opinion, we have forgotten how we got rich. We don't know how we got so rich, what our parents and our grandparents had to suffer, and where we had to, what we had to do to build up our own wealth, and also the institutions that are related to that. So, and a very good example of that, not too long ago, and I think that's something that we must every time again try to keep in the back of our mind, a little bit critical on public health then. Joep was the first person, or one of the first, with a small group of people that put HIV/AIDS treatment on the agenda. And it has taken the Public Health Society up to 2004 before and already 20% of the population in Southern Africa was infected before something happened. And that is not something that is to blame on the public health people, but it shows that institutions are very, very difficult to change. And it's a clear example that I think we have to look for things that are basically unacceptable. Why is it that in the Western world everybody gets treatment and not people in Africa or any other poor places? That's one thing. And the other thing is the same for, I think, the capital thing, the interest rates. It's an unbelievable thing that this is possible and that nobody is really putting it on the agenda. And I think that is a starting point. And from that, you can start to change. But things that are absolutely true, they depoliticalize the debate, and it's a starting moment for change, I think.
Yeah, thank you all. I think there are a lot of themes that came out of this, many of which sort of tied together. The idea of involving the providers in the community, the idea of taking a cooperative approach, the idea of looking for the synergies between research and technical assistance and the private sector, the idea that there's now a private sector to talk to, and governments are starting offices to actually talk to them, and there's actually a government that's listening. But I do want to look at some of the potential fissures as well. I mean, when we think about the private sector, the essence of the private sector is competition, and yet you made the point that only the cooperative approach is what needs to be part of the solution. Can you square that circle?
Is it to me or to you?
To both of you.
To both of you. What I think is interesting now to say, if I look at the picture of Lagos, for example, in there, yeah, and you see all these accredited facilities in there, and you see that there's a huge potential for investment of the private sector in medical care, right? But one of the problems, if you want to separate medical care a little bit also from public health, is, well, underneath that, there might still be a lot of problems with all the sewage, with all the stuff, which is getting people to the hospitals. So there needs to be a very strong collaboration in there. Otherwise, with all your investments in the private sectors, you're building castles on sand in there. Yeah? And that's these type of things where we have to do it. If it seems indeed that the private sector is very good in generating money to provide the medical care, giving a cost-effective package, in raising donors, a pre-polled mechanism, if that is all true, then it would indeed make sense to say, okay, government, raise your levels for public health. Don't look at all this medical care stuff anymore, but start building sewage and toilets and other things in the public. That these type of discussions have to take place then and there. And I think I'm really interested to see what's going to happen in Lagos. Your hands are burning to see what are the results coming from that in there.
In the countries that I am talking about are countries like Sudan or Afghanistan or Congo. That is where you do not find any private sector that lives up to standards of quality. That is where you do not have any kind of legislation as yet for how insurance systems should work. That is where you, in other words, have lots of opportunity to start working on schemes that might help to develop in a direction that would also, and that I think is the key issue, in a situation where no government has credibility as yet, you will find people able to invest in their own healthcare systems and therefore start mobilizing a civil society that will eventually yield private practice. And that would be the next step, I think.
Well, I want to turn that to Monica, because you run a privately funded health system, but it's not for profit. Anyway, how do you coexist in a world with for-profit providers, some of whom are not maintaining the same standards of quality that are demanded by, for instance, Tobias and his Safe Care program?
Yeah, in the private providers network that Kimet runs, actually everybody is involved, and they are at different levels. We have the consultants who are at the tip of the pyramid up. Then we have the general practitioners or the medical officers who are also in the network, and the majority are the mid-level providers. In Kenya, the mid-level providers are the nurses, midwives, clinical officers, because they are the majority at the community level. As you go down, at the grassroots, where most people really need the quality of care, you get the mid-level providers. But we still go down and work also with the community-owned resource persons. In those rural communities, we have the other cadre of the informal private practitioners, in quotes, the community health workers, because these are the people that most of these communities recognize. They are the ones they see as the doctors. So most of the times they even go to these community health workers. I heard of another presentation which we were looking behind to decide the way forward. Most of the times in the rural communities in Kenya, they were the community health workers, the traditional birth attendants, the herbalists. They still exist and they are consulted. So the network is managed by the network providers themselves. Every year they meet. There is a network meeting every year where they discuss their issues, their challenges, and they even hold the government accountable for some of the other challenges that they encounter. So although the government has not really appreciated, as Professor Rogo said, the role of the private sector. So that is something that the network is now trying to address, and they want the Minister of Health, we have two ministries, to really appreciate the role of the private sector, because most of the times they are seen like they are in business, but they don't see the role they play to ensure that the services are accessible. So within the network, they also have their policies, they have a steering committee, they have their supervisors, they are even a peer supervision to ensure that standards are met at all those levels that I have mentioned.
Thank you. One of the moderators has lost his voice. We are far in the day, but I think that we may do one short round of very burning questions from you to whoever you want to address those questions before we have a final word from somebody who will introduce shortly. Who is... I'll come and give you the microphone.
I think social hands hit the nail on the head. It's really critically important that we integrate community health, looking at water sanitation. I was absolutely amazed to hear that there wasn't an answer to preventive medicine. Preventive medicine is absolutely essential. Management of TB and with spraying. We're not using DDT at the moment, but we should find some alternative or maybe go back to it. And then building up on programs like Safe Care, which goes from... So the question is, how do we integrate all of those and how do we fund it?
There's a spectrum of activities from the pure public to pure private. But there's a middle line here that we often do not pay enough attention to. And this is where the opportunities for public-private partnerships come in. Things that benefit with major public health benefit, but may not necessarily be profitable, fall very, very much in this middle category. And we are seeing already public-private partnerships in the delivery of water, safe water resources in slum areas in Africa. That management is the key thing. Not that there's no water, but the management is in. We've seen that in the delivery of HIV medications and in malaria bed nets and so on. So that efficiency, private sector efficiency in bringing that one in, and governments accepting that we are not the best to deliver that. But it's not only in countries where you have established government. Our experience is that post-conflict countries with that fragility coming out of it, like South Sudan as an example, gives us a unique opportunity for public-private partnerships. Because already during that conflict period, the private sector is the only delivery mechanism that exists. There may be NGO, there may be the other. But then the government has not been entrenched enough for you to have this resistance that we have in established governments that do not want to give anything away. So we've seen, and my colleague Dak here will tell you, that actually we are finding more responsiveness from those governments and from established ones. So when it comes to infrastructural issues, the question here is, what is the most efficient way of delivering it? And how do you bring that business acumen into making it happen? We are seeing it happen in the water area, in the disposal, waste disposals and so on, in urban and peri-urban areas. And we are seeing it too. In fact, some of the latest agreements that I've seen on public-private partnerships are on the pharmaceutical supply chain. You know, that is the biggest headache that we've had in our countries. Governments have been trying to do it, it does not work. And yet private sector is doing it cheaply, including the delivery of Coca-Cola. So how you bring that to deliver medicine becomes a key thing. So here is one place where the government resources that are being wasted at the moment can be employed much more effectively by the private sector, and PPP is the answer. And finally, there's an issue of lease issue. Why do governments buy an X-ray machine and own it, but it is down 90% of the time? Why can it not lease at the same price and it is up 120% of the time? These debates are now coming up, and you're beginning to see governments now willing to go on public-private partnerships in this expensive equipment, in the running of ambulance services, and so on. So here is an opportunity for us to make sure that the private sector is not just seen at the extreme end, but that is also in the middle and can work with the government effectively.
Just one, I think, with all what has been said, that there's still, with that shift in roles and private sector moving in, it does mean also that the government must keep a very sharp eye on what is happening to the poorest of the poor, and in terms also of equity. Because in that sense, I still would like to say, yes, people are taking loans now to make their business, but these loans will need to be repaid. And that means that it's going to cost patients something to them. So the question is, yes, access is being increased, but access for whom is then the question. And that means, I think, also a very sharp role of the government to continue looking at, is it really also of interest to the poor, or should we, as a government, make our own strategies also within the public sector or in combination with the private sector to ensure that also these people benefit. Okay.
There's a question.
Anita has a question.
Oh, Anita, and then over there. But before she speaks, it's worth noting that if you want to know more about how to engage the private sector in public-private partnerships, there's a shiny blue book the IFC just came out with to describe all the ways that can happen.
Thank you.
Yes, I've done. Sorry. As an anthropologist, I've done a lot of work at the bottom of the pyramid. And one of the findings from our studies on health-seeking practices in Asia, slums, urban poor areas, is that 9 out of 10 drugs are taken in self-care. And I guess self-medication is kind of important. It's from the private sector, but it's from pharmacies. So I think it's a good idea for the medical credit fund and the self-care, I call it self-care, safe care initiative, to also look into pharmacies as places where quality can be improved if you want to improve care for the bottom of the pyramid. Also, in terms of the way to assert quality, I think community involvement is very important. And throughout Africa, through all the AIDS care programs, we have very many support groups who are looking at AIDS access and AIDS quality. But I think this is a new development that we can use, of collectivities of patients that can be used to improve quality. So it's not only kind of coming top down to measure quality, but also a demand for quality. And that could lead to more trust.
If I may, this is just answer this one, because this is exactly what's happening at the moment with safe care, not self-care, but safe care. That indeed the pharmacies and the chemistry shops have been identified as one of the key entry points of everybody in Africa to get to their drugs, and we will include them in our next series of quality modules and so on. So thank you for that comment.
It was a small comment. Actually, it was picked up a little bit, and I think you've adjusted for a little bit of the imbalance by some of the latest speakers here, saying that the role of government has to be also, I think, very much underlined as very, very crucial to be able to work with equity when you are involving private sector, as you have been talking about the whole of the day. And up to now, the evidence is stating that the more private sector is involved, the greater the chance for inequity in the society and in the healthcare delivery. And I think we really have to have good systems at hand so that those most needy populations are also taken care of in this situation. And coming from Scandinavia, I must say it's also interesting to have a little view on the role of the government. You know, in Scandinavia, and I will also say in the Netherlands, it's a fully funded government system. And compared to an American system, which is fully privatized, we are delivering this health services in Scandinavia for the half price of what they do in the US. So we really have to work on finding those good ways of using the private-public partnership in this new developments in Africa. And when it comes to quality, just a small comment. To have quality standards, you really need to have the good evidence, as was said before here from our friend from South Africa. And KIT is now working with 8 partners in Africa to try and improve also a collaboration for evidence-based healthcare and deliverance of the best standards and guidelines into the healthcare system. Thanks.
As a representative of the U.S. health system, I just want to say I certainly don't mean to defend it, but one challenge of it is an area where you have a lot of private sector and a lot of public sector action. Half our healthcare is paid for by the public sector, but it's all uncoordinated. And a big point that was made here is that part of what you need to do is bring these things together in a rational way, not sort of just let everyone do their own thing and have people try and push costs from one place to the other. Max has a question as well, but before Max, I just want to ask Kama one thing. You made some points about some successful public-private partnerships in Africa, but a big theme of a lot of the speakers today was the limits of the institutional capacity within Africa. Is it your sense that the types of issues that were raised about sewerage and water and things like that can be dealt with by the governments in Africa today, or at least a significant number of them?
Anybody who comes to work in Africa, when you ask them what the problem is, they tell you that there's problems of capacity. And then when they set up their company, you find that 99.9% are Africans, and there's 1 or 2 people who've come from abroad. So I don't know whether that 2 or 3 people are the capacity that they're talking about. There are capacity deficiencies, but there's also utilization of the capacity that exists. And this is where the government fails most. I'll give you an example. If you have a hospital, a nurse working in a public hospital, always late, always sleeping on the job, and so on. That same nurse does a night shift in a private hospital next door. Always awake. She's Angel Gabriel, welcoming people, very smiling and everything else. Not a single minute of training has been given to that person. And then people will say that the public sector has no capacity. The thing is that we are not using existing capacity. That's clear. We have people in the wrong places. The top surgeon is the medical superintendent of a big hospital. He doesn't know how to manage a hospital. So these are some of the things. And then there's a question then of what capacities and how do you build them? Yes, there will be shortage in there, but that is where too we feel that the private sector has a role. Why do I say so? Africa, for the last 60 years of our independence, has relied on public universities to produce doctors and nurses. Public medical schools in Africa has been increasing at a rate of 1 every 15 years. Take Kenya and work it out. So if they're producing 100, then they produce 200, but 15 years later. For countries whose population double every 15 years, Right now, East Africa alone sends and trains more doctors in India, paid for by their parents, than is produced by the universities in Kenya, Uganda, Tanzania, and Rwanda. It is time that the private sector that they go to in India is produced in Kenya and Uganda to produce these people and nurses. And we're beginning to see that happening. So local production cannot just be left to the public sector, and the private sector has a role. And if that private sector also gives employment, quality employment, then we will retain our people there. The data is this. If you look at the movement of health professionals in Africa, countries with the weakest private sector have lost more doctors than countries with a stronger private sector. Compare Tanzania over the years before it changed to where Kenya is, and you'll see where your data is. So we have a role here of both utilization, production, but most important, let us use the resources that we have.
Thank you, Kama. Max, I think we will give you the last chance to ask a branding question or make a smart comment or something.
It has to do also with I have a request to Kama. It takes me 2 minutes to ask you the question. IFC in the past has had a very successful investment in Celtel, as you know. It took Celtel 4 countries to be operationally positive before any international investor was interested to invest in Celtel. They were having even no audience in the West. So now, if we want to set up an insurance provider in a few key countries in Africa, we know all the technology that's needed for that. We can bring it from the West and put it in there. Clearing houses, identification systems, let's say efficient systems of supply of medication, and so on and so forth. We can talk about the elements. Are you willing to set up together with us a task force from IFC, African Development Bank, and a few private investment companies to go for that dream?
Your question took 2 minutes. Mine will take 1 second. Yes.
Well, I think that's a good note on which to end this panel. Thank you all to the panelists. I thought this was a great conversation. Thank you for the questions.